Hello everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Saxe Healthcare Communications, and I'm your technical producer. It is my pleasure to welcome you to today's webinar, Recognition and Management of the Neonate with Pneumonia. And now, I'd like to introduce you to Dr. Marlene Walden, who is our moderator today. Marlene is currently the Nurse Scientist Manager at Arkansas Children's Hospital, Little Rock, Arkansas. She has 37 years of critical care experience, primarily in the neonatal intensive care unit, a successful principal investigator of numerous clinical studies, and as a nurse scientist, Dr. Walden has mentored dozens of nurses in designing and implementing clinical research studies. Dr. Walden is a member of the Research Committee for the National Association of Neonatal Nurses. In 2017, she was awarded the Excellence in Research Award from the Society of Pediatric Nurses, and she has been inducted as a fellow in the American Academy of Nursing. Marlene, welcome, and I'm so glad to be working with you for this special session. And we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
Yes, thanks Emily for that kind introduction. Thank you for joining us for this webinar on recognition and management of the neonate with pneumonia. Speaking on this topic is a dear friend, colleague, and neonatal expert who is at the forefront of this very important clinical topic. Dr. Therese Verklen is a professor at the University of Texas Medical Branch School of Nursing in Galveston, Texas. She serves as a co-editor of the core curriculum for neonatal intensive care nursing, as well as is a chapter contributor. She has been a guest editor for the Journal of Obstetric, Gynecologic, and Neonatal Nursing's Clinical Issues in Critical Care Nursing Clinics. She's a reviewer and editorial board member for a number of professional journals and is an associate editor for the Journal of Nursing and Health Sciences and a contributing editor for the Journal of Perinatal and Neonatal Nursing. Dr. Verklen has disclosed no conflict of interest and no off-label use in this webinar. This activity has been approved for 1 contact hour of continuing education for nurses and respiratory therapists by the accreditation organizations listed on this slide. At the end of this webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of this webinar. We are grateful for the education grant from Philips that supports this webinar and allows us to offer this online learning opportunity. And now I would like to turn over the presentation to our speaker who will discuss the recognition and management of the neonate with pneumonia. Dr. Verklen, are you ready to get started?
I am. Thank you, Marlene, for that very kind introduction. And I'd like to also extend a welcome to all of you who have joined us today for this webinar. Our learning objectives for today are to differentiate early onset pneumonia from late onset pneumonia, discuss signs and symptoms associated with pneumonia, identify necessary diagnostic testing to establish a diagnosis, formulate a plan of care for the neonate with pneumonia that includes treatment strategies, and discuss complications associated with pneumonia and how they may impact the severity of the disorder. The newborn lung is susceptible to bacterial and viral infections, and neonatal pneumonia is a major cause of morbidity and mortality worldwide. Diagnosing pneumonia in the newborn period can be very challenging. Compared to older children, neonates show fewer localizing signs of pulmonary infection. Pneumonia frequently manifests as a systemic deterioration involving multiple organ systems. Common non-infectious respiratory complications of prematurity often coexist with and exacerbate pneumonia. And even when pneumonia is suspected, the technical barriers to lower airway sampling in small infants may render conclusive identification of an organism impossible, which means we need to think very carefully about what therapies we're going to provide for these babies. We're going to talk about risk factors, pathophysiology, diagnosis, and treatment of neonatal pneumonia. And to do this, I've organized the discussion around 3 disease subtypes. There's congenital pneumonia, where the infection is established during fetal life that may result from an ascending infection across the chorioamniotic membranes or a transplacental route. Early onset pneumonia develops within the first week of life and results from perinatal pathogen exposure, either intrauterine or during passage through the birth canal. And late onset pneumonia, which also includes ventilator-associated pneumonia. That develops after the first week of life from environmental, often nosocomial pathogen exposure. So looking at risk factors. Compared to children, newborns have a limited capacity to defend against pulmonary infection. Immature innate immunity, both systemic and that localized to the respiratory mucosa and lung tissue. They're a fundamental risk factor for neonatal pneumonia. It's more significant in premature and growth-restricted patients. Adaptive immunity, mostly in the form of maternally derived immunoglobulin G, is rudimentary in the immediate newborn period. Preterm babies less than 32 weeks have very little IgG. And adaptive immunity requires antigenic exposure during infancy and childhood in order to establish strong protection. Structurally, the newborn lung has key deficiencies in important barrier functions that provide a first line of defense against infection. There's a relative paucity of alveolar macrophages, and that coupled with impaired mucociliary clearance of debris permits establishment of early colonization by potential pathogens. Surfactant deficiency because of prematurity has been linked to enhanced growth of group beta strep and subsequent deterioration. And there is evidence that pulmonary infection inactivates existing surfactant and damages type 2 pneumocytes, preventing replenishment. And on this slide, you see the type 2 pneumocyte. The surfactant is made and then stored in these laminar bodies. And so the surfactant pool, especially in our preterm babies, is decreased, and then having an infection will decrease that pool even further. Phagocytosis by neutrophils recruited to the lung is an essential first step in clearing pulmonary bacterial infection. But neonates show multiple forms of neutrophil dysfunction. Approximately 2% of term and 5% of preterm newborns have neutropenia. They also exhibit a blunted neutrophil recruitment from the bone marrow in response to infection. And they have defects in neutrophil chemotaxis to sites of inflammation. Chemotaxis is, you can think of Hansel and Gretel putting breadcrumbs down on the ground so they can find their way back home. That's what chemotaxis is. It tells the neutrophils exactly where to go to the site of infection. And we know that neutrophils derived from preterm infants are especially affected. The efficiency of pathogen clearance by recruited neutrophils and phagocytes like macrophages and monocytes is dependent on opsonization with complement, antibodies, and other nonspecific binding proteins. And you can think of opsonization as a marker. Say you meet somebody for the first time and you put a flag on their shoulder, and the next time you see them, you're going to instantly recognize them. That's what opsonation does with foreign cells. Unfortunately, the neonate has lower levels of many complement components and lacks specific antibodies, which limit the capability of the immune system to mount an effective response to pneumonia. Let's look at some maternal risk factors. Congenital pneumonia results from a maternal infection during pregnancy and typically presents as one component of a systemic illness. Congenital toxoplasmosis, for example, that's due to a primary maternal infection by Toxoplasmosis gondii. The main maternal risk factors are eating undercooked meat or exposure to cat feces during the pregnancy. The risk of transmission to the fetus increases with gestational age, but severity of the illness decreases as pregnancy progresses. Neonatal pneumonia can be one sign of congenital cytomegalovirus infection, which affects up to 2% of pregnancies. Mothers who develop a primary CMV infection during pregnancy are at the highest risk of delivering an affected newborn. Transplacental transmission rates are up to 40%. The risk of vertical transmission is highest if mom's infection occurs during the first half of pregnancy. A severe, often hemorrhagic viral pneumonia may be one sign of a disseminated herpes simplex virus infection. Respiratory distress is a presenting feature in about half of these cases, and typically the baby shows symptoms during the first 2 weeks of life. Disseminated HSV usually results from an ascending intrauterine infection or intrapartum exposure to the infected genital tract. The major risk factor for neonatal HSV is a vaginal delivery in the setting of a primary maternal infection with either herpes simplex 1 or 2. Cesarean section or prior maternal exposure to either herpes subtype will reduce the risk of transmission considerably. If mom has her primary infection, the risk of transmission is about 50%. If she had her first infection before this pregnancy, then the risk of transmission to this baby is less than 5%. Looking at perinatal risk factors for early onset pneumonia. Choreo is our key risk factor for pneumonia. Inflammation of the decidua and chorioamniotic membranes signal microbial invasion of the fetal placental unit. It can be accompanied by a very powerful inflammatory response syndrome by the fetus that will induce structural remodeling of the lungs. And what it does is lead to a simplification of the cellular architecture and increases the odds of later pneumonia or chronic lung disease. Choreo in FERS may also trigger preterm rupture of the membranes and subsequent preterm labor and delivery, which will further compound the pneumonia. Risk factors for early onset include prematurity and low birth weight, low socioeconomic status because that is so tightly tied to quality health care, male gender, colonization with a known pathogen like group beta strep, premature rupture of membranes or prolonged rupture of membranes, especially more than 18 hours, and galactosemia. There's an increased susceptibility to infections with gram-negative organisms. Risk factors for late onset pneumonia. The main ones here are prematurity, low birth weight, and duration of mechanical ventilation. And because these risks are often correlated, it's very difficult to conclusively establish the independent contribution from each cause. Different studies have reached varying conclusions. And then we have other risk factors for that include prior bloodstream infections, low nurse to patient ratios, inadequate environmental air filtration, frequent suctioning. That's defined as being suctioned more than 8 times per day, and sedation while intubated. Looking at the pathophysiology. During an acute intrauterine infection, bacterial or viral growth grows in amniotic fluid. That allows direct contact between the pathogen and the fetal respiratory mucosa. Pathological examination of lungs from stillborns or babies who died of early onset pneumonia routinely identify leukocytes of maternal origin and aspirated amniotic debris. That supports the concept that congenital or early onset pneumonia may arise from direct mucosal seeding from infected amniotic fluid. Meconium aspiration increases the risk of pneumonia by decreasing the antimicrobial properties of amniotic fluid. And it also serves as a vector for bacterial entry and postnatal persistence in the lungs. Another opportunity for pathogens to enter the neonatal respiratory tract occurs during passage through the birth canal. Maternal vaginal colonization with GBS is a key risk factor for early onset GBS sepsis, including pneumonia. In the absence of prophylactic antibiotics, approximately 50% of infants born to GBS colonized mothers will become colonized intrapartum. Aspiration of respiratory secretions containing GBS will progress to pulmonary infections that quickly lead to a full-blown sepsis. And the same progression from intrapartum mucosal colonization to early onset pneumonia has been identified for E. coli, chlamydia, pneumococcus, and Haemophilus. Late onset pneumonia results from colonization of the oropharyngeal mucosa by a potential pathogen, which then seeds the lower respiratory tract. Late onset pneumonia that develops in the hospital is often termed healthcare associated pneumonia instead of nosocomial pneumonia. And there are multiple drug-resistant bacteria that are causes for healthcare associated pneumonia. The source of initial oropharyngeal colonization leading to pneumonia can be exogenous or endogenous. Common exogenous sources include caretaker skin, which is typically the hands of a medical professional, contaminated equipment, or environmental surfaces. The main endogenous sources of microorganisms responsible for late onset pneumonia are the nasal and oropharyngeal mucosa. Pooled oral secretions in the posterior oropharynx can foster local overgrowth of pathogenic species. And then the baby aspirates those, and that sets the stage for pneumonia. An intubated, especially a sedated intubated newborn with an uncuffed endotracheal tube, which is what we all use, is at high risk for passage of infected secretions into the lower airways. That means we need to pay careful attention to the head of bed elevation and adequate tracheal suctioning. Among intubated infants, the endotracheal tube itself represents an important reservoir for microorganisms. Studies have demonstrated early and progressive growth of bacterial biofilms on the outer and inside surfaces of the endotracheal tube. The endotracheal tube biofilm tends to be enriched for potentially pathogenic species, such as Staph aureus and a variety of gram-negative bacilli. Patients who develop BAP show a high correlation between microorganisms colonizing the endotracheal tube and cultured tracheal secretions. The artificial surface of the endotracheal tube and the biofilm increase bacterial resistance to antibiotic therapy. And additionally, the endotracheal tube serves as a foreign body that impairs mucociliary transport and prevents effective coughing, which further limits debris clearance from the lower airways. In the case of bacterial pneumonia, initial cell injury results from direct exposure to bacteria-secreted and surface-associated toxins. CMV, or disseminated herpes, triggers lytic or apoptotic loss of pneumonites. Loss of the alveolar surface interferes with surfactant function, allows transudation of pulmonary edema, and culminates with alveolar collapse. The inflammatory response triggered by pulmonary infection can also cause significant injury and dysfunction. Neutrophils that are recruited to the lungs serve primarily as antimicrobial phagocytes, but they also secrete reactive oxygen species and other tissue-damaging molecules. This is particularly true of the older neutrophil. Airway obstruction from bacterial and inflammatory debris, combined with smooth muscle contraction due to inflammatory mediators, impairs effective ventilation. It also promotes atelectasis, air trapping, and subsequent ventilation perfusion mismatching. Inflammatory procoagulants and vasoconstrictors released by activated endothelial cells and platelets increase pulmonary vascular resistance, which can potentially trigger a pulmonary hypertensive crisis. That already limited surfactant pool is going to fail further, and we end up seeing a severely ill patient with failing respiratory and circulatory systems. Our clinical presentation includes a mom who has a labor greater than 24 hours, prolonged rupture of the membranes, we mentioned greater than 18 hours especially. The labor and delivery nurse may tell you mom had a fever or there was evidence of choreo, that there was foul smelling or purulent amniotic fluid. The fetus may have developed tachycardia or shown decreased fetal heart rate variability. Signs and symptoms are often indistinguishable from other forms of respiratory distress and sepsis. Tachypnea is generally the first sign that you see. It's the first sign that you see for any baby showing distress. But there could be grunting and retractions, cyanosis, hypoxemia, hypercapnia, and hypoglycemia. With severe involvement, a shock-like syndrome can be seen, typically within the first 24 hours of life. Baby shows recurrent apnea, followed by cardiovascular collapse, profound hypoxemia, and persistent pulmonary hypertension. And those last signs represent a very poor prognosis. As you do your physical examination, you're going to see that the symptoms are variable. You may say that you hear decreased breath sounds that are present over one or more areas. You may have localized dullness or harshness or hear rales. And radiologic findings can mimic those seen with RDS. In addition, pleural effusions may be seen on chest x-ray, especially with a GBS pneumonia. This baby's mother had choreo. She had been treated with antibiotics for a week, but then the fetus developed signs of distress. The baby was born in a very poor condition. It was very foul smelling at birth, and then when the blood work came back, he had a left shifted full blood count. Cultures were negative in the baby despite the abnormal appearing chest x-rays. The anterior-posterior film on the left shows patchy bilateral opacity, more marked on the right. No effusions are seen, although these are pretty common with infections. And the lateral image shows patchy consolidation, particularly in those lower lobes. And despite repeated cultures, we could not identify a single organism for that infection. The diagnosis of neonatal pneumonia is based on a combination of physical examination findings, radiographic evidence, and supporting lab data. The Center for Disease Control and Prevention have criteria for diagnosing pneumonia, and you see that on the slide. They want radiographic evidence of a persistent consolidation or pleural effusion and evidence of worsening gas exchange, plus at least 3 additional clinical and or laboratory findings. That can also be diagnosed in patients who have been intubated for at least 48 hours and meet the criteria for pneumonia. Unlike other frequently occurring neonatal infections, such as a bacteremia or a meningitis, identification of a single pathogen causing pneumonia is often not possible. Invasive lower airway culturing methods, such as bronchoscopy with protected brush sampling, are sometimes used in pediatric ICUs, but invasive airway sampling is not considered a first-line diagnostic approach in the neonatal intensive care unit. Pneumonia can lead to hematogenous seeding and bacteremia, but a positive blood culture is neither necessary nor sufficient to diagnose pneumonia. Clinical and lab assessment of suction tracheal sputum can be done. We know increased production, especially of a purulent sputum, is an important diagnostic criterion. Cultures of tracheal sputum rarely yield a single organism, but a gram stain of tracheal sputum that shows a leukocytic infiltrate and the predominance of a single bacteria type, for example, gram-positive cocci in pairs and chains, that would suggest GBS, that suggests pneumonia caused by the dominant microbe. And serial gram stains of suction sputum during treatment can be used to track disease resolution or persistence. Congenital infection with CMV, herpes, or toxoplasmosis, you'll be asked to obtain blood for liver function tests, including coagulation profiling, urine culture for CMV, surface cultures for herpes. You'll assist with a lumbar puncture so that you can obtain cerebral spinal fluid cell counts, differential, a culture, and polymerase chain reaction for herpes and toxoplasmosis. Late onset pneumonia caused by a viral infection can be indistinguishable from a bacterial disease. And there are a variety of high sensitivity, high specificity PCR and enzyme-linked immunosorbent assays for specific viral testing. Hospitals can now run comprehensive rapid multiplex testing from a single sample of suction pharyngeal sputum. While we're waiting for the cultures to come back, you'll be thinking about a differential diagnosis. Is the baby showing us worsening respiratory distress syndrome, a sepsis, or a meningitis? Maybe transient tachypnea of the newborn? Meconium aspiration we sort of know about because there's meconium somewhere. Maybe he has lung hypoplasia or pulmonary hemorrhage, or he's showing symptoms of congenital heart disease. Treatment for congenital or early onset pneumonia, ampicillin and an aminoglycoside like gentamicin is the appropriate starting regime. Cefotaxime can be substituted for gentamicin when there's a strong suspicion of bacterial meningitis. If there's sufficient concern for herpes, acyclovir should be started immediately. Standard treatment for congenital toxoplasmosis is pyrimethamine and sulfadiazine plus folinic acid, and the baby needs to be treated for the first year of life. Recent recommendations for treatment of infants with congenital CMV suggest at least 6 months of treatment with valganciclovir to decrease the extent of neurologic sequelae. For late onset pneumonia or VAP, choosing antibiotics requires a lot more thought. You have to give thought to what the local patterns of bacterial antibiotic resistance are. Every NICU is a little different. And the patient's history. How many previous infections has he had? What types of organisms caused the infections? And when did he have them? At a minimum, initial therapy should include 2 antibiotics with coverage of most drug-resistant gram-positive and gram-negative species. One of the antibiotics must have activity against methicillin-resistant Staph aureus. That's a frequent cause of ventilator-associated pneumonia that's associated with very poor clinical outcomes. Vancomycin and linezolid are acceptable anti-MRSA choices. Choices for the second antibiotic include piperacillin, tazobactam, or gentamicin. Severely ill patients with late onset pneumonia should be started on a 3-drug regime, of course tailored to the baby's clinical history and what is growing in the NICU. Antibiotic therapy should continue for a minimum of 7 to 14 days. Longer treatment may be warranted in cases of severe persistent illness or if there is concurrent infection beyond the lungs. There really isn't a clear consensus on what the optimal course should be. A 10-day course of therapy is a reasonable starting point for an uncomplicated pneumonia. And that can be modified, of course, as circumstances require. Complications of pneumonia include cardiopulmonary complications, very similar to those of RDS, systemic inflammatory response syndrome, disseminated intravascular coagulopathy. DIC always needs to be thought of anytime you have a sick infant. Persistent pulmonary hypertension, and meningitis. The American Thoracic Society and Infectious Diseases Society of America have published guidelines for reducing the incidence of hospital-acquired pneumonia, including ventilator-associated pneumonia. Recommendations focus on limiting opportunities for cross-contamination between caregivers and patients, decreasing tissue damage from prolonged or recurrent intubation, avoiding unnecessary medication that may promote infection and or antibiotic resistance, and maximizing oral hygiene and pulmonary toilet. Many hospitals have adopted VAP bundles. It may surprise you to know that there is no standard VAP bundle for neonates currently. So practices vary among units, as does the level of evidence for each bundle component. But overall, there is evidence to suggest that care bundles do decrease the risk of VAP. No matter what type of bundle that you use, you should have these components in that bundle. Hand hygiene needs to be paid attention to. Meticulous hand hygiene before and after patient contact and handling respiratory equipment. Of course, we wear gloves when handling ventilator condensate and any secretions, respiratory and oral. Intubation. You should use a new sterile endotracheal tube for each intubation attempt. I've seen places where they pull the tube out and then place the same one back in when they're trying to intubate the baby, especially if it's the first time. Ensure that the endotracheal tube does not contact environmental surfaces before insertion. The laryngoscope should be sterilized. And there should be at least 2 NICU staff members present for endo-tube retaping or repositioning. You want to clear secretions from the posterior oropharynx prior to any endotracheal tube manipulation, patient positioning, extubation, and reintubation. Think about your feeding practices. You don't want to give volumes that result with gastric distension or overdistension. Monitor gastric residuals, although many hospitals today are no longer routinely taking residuals or looking for residuals. And then adjust the feedings to prevent large residuals and or distension. So you may feed the baby over a longer period of time, especially if he's being fed with a pump. Think about positioning. You can use the sideline position if the baby tolerates that. You want to keep the head of the bed elevated at least 15 to 30 degrees as the baby tolerates. You can use the left lateral positioning after feeds if he tolerates that. There are studies that show that the stomach empties faster, so that's important if you have a baby with chronic lung disease at risk for VAP and he has gastroesophageal reflux. Oral care is also very important. It should be provided within 24 hours after intubation, every 3 to 4 hours, prior to reintubation as time allows, prior to orogastric tube insertion. You can use sterile water, mother's milk, or approved oral care solution. And then either the nurse or the respiratory department takes care of the respiratory equipment. So you use a separate suction catheter, connection tubing, and canister for oral and tracheal suction. It's either your responsibility or the respiratory therapist's responsibility to drain the ventilator condensate away from the patient every 2 to 4 hours and always before positioning. Avoid unnecessary disconnection of the ventilator circuit. We change the ventilator equipment when it's visibly soiled, and we use heated ventilator circuits. So in conclusion, pneumonia is a frequent form of infection among hospitalized neonates. The age of onset and surrounding circumstances, including maternal history, may provide important clues as to the etiology and may help guide initial treatment decisions. Early intervention with broad-spectrum antibiotics is crucial for preventing systemic infection and the worst complications of pneumonia. I thank you very much for your attention during this presentation and look forward to hearing your questions. Let's go back to Marlene.
Thank you, Therese, for this most informative presentation. We've received quite a few questions, but before I get to those, I would like to remind you that this webinar has been approved for 1 contact hour. You can obtain those continuing education credits by logging on to saxetesting.com/BO. To obtain your continuing education credits, you need to register on the test site and complete your evaluation form. And when you get that done, you'll be able to print out your certificate. Again, I would like to thank Philips for their support of this webinar through an education grant. Also, I would like to remind you the on-demand webinar is also accredited for continuing education credits. Okay, so let's get right to our questions you submitted. So our first question is from Julie, who wants to know, at what angle should the head of bed be elevated for the neonate to prevent pneumonia?
It should be elevated 15 to 30 degrees, and I would prefer having it up more towards the 30-degree mark to prevent the pneumonia.
All right. Another question comes from Ula Omi, who wanted you to further explain how low nurse-patient ratios would be one of the factors causing ventilator-associated pneumonia.
Oh, that's a great question. In the NICU, you typically have one nurse to 2 patients. There are some NICUs that have 1 nurse to 2 ventilated patients and maybe a grower feeder. And when you have those kind of scenarios, you can't pay as much attention to those intubated babies as you need to. So their secretions may pool, they may show signs of illness that are not picked up because the nurse is rushing around and she's not catching that the baby's general condition is very subtly changing. So it's recommended that when you have ventilator patients, no more than 1 nurse should not have more than 2 patients so that she can watch them very carefully and observe for any changes in their condition. And of course, you also need good care for the mouth. And if you have 3 babies and you're rushing around, nurses tend to look at most important things, and most important things may not register as good oral care to prevent that, for example. So it's just the increased workload that the nurse has and how she or he has and how they prioritize their care.
I think that's a really important topic, that nurses struggle with and organizations struggle with is providing that right patient-nurse ratio for the patients that we care for, because sometimes our patients are a little bit different than other patient populations, and so that's really, really important. Thanks for that question. We have a couple of questions that has to do with like equipment. Janet asked, do you recommend a minimum frequency for ventilator circuits to be changed?
I believe the ventilator circuits are changed out every 72 hours and earlier if they're soiled. But those policies depend on the individual hospital, I believe. But I think it's pretty typical for 72 hours.
Right. And there was a question from Bonnie as well about, is the use of a sterile laryngoscope unique to the NICU environment?
It shouldn't be. I believe, I haven't worked in an adult ICU for, I don't want to tell you how many years, but all laryngoscopes should be sterile when they're used.
Right.
Pediatric, everybody.
Right. Yeah, I think, we have a policy where like our central supplied sterile processing one actually does that and actually provides that at the bedside and in like the delivery suites for a baby so that we have sterile equipment.
Absolutely. So nobody should ever use a laryngoscope that is open and kind of sitting around. You want to make sure that the sterilized package has the signs on it that it's been sterilized. There's places on it that change color, and then somebody physically opens that when it's time for it to be used.
So there's a question back, going back to like the ratio, when we're talking about, because our care in the NICU is so interdisciplinary and respiratory plays a key role in the care of our babies with respiratory distress. Alicia wants to know, is there any suggestion for the ratio of respiratory therapists for ventilated patients?
I don't know if there is a specific ratio. I know that hospitals all have different ways that they work with the respiratory people. So for example, the hospitals that I have worked in, we've had dedicated neonatal respiratory therapists, and they were assigned so many patients, including babies that are not intubated. They may have oxygen tubing, etc., high flow nasal cannula, etc. There are other hospitals that have a pediatric respiratory therapist instead of a neonatal, and that person is responsible for both the NICU and the PICU. And so they're often not around to provide that type of oral care or care of the tube and the ventilator equipment, and then it falls to the nurse's responsibility. So it all depends on how your hospital is set up.
Great. Several individuals have asked for more information on oral care. So Elaine asked, what oral care is done specifically? There's a question from Destiny that asks about what solutions. I know we talked about colostrum. There was a question, Mitchell asked about, is it recommended to do mouth care with colostrum for intubated patients? And then there's a question from Destiny about chlorhexidine, which I haven't heard about. She talks about it's used for adults in oral care for ventilator-associated pneumonia prevention, but is there a weak solution or something similar for neonates? So a lot of questions about the process for oral care and the solutions for oral care. Can you talk a little bit about that, Therese?
Okay. The oral care should be done every 3 to 4 hours depending on the baby. Typically, it's done around feeds, or if the baby is not feeding, then it's typically done on a Q4-hour schedule along with taking vital signs and doing your assessments. There are a number of different type of swabs that you can use to place in the mouth. They used to use those glycerin swabs way back when, and we thought those were really good at providing care, but it was shown that the glycerin really ended up drying out the oral mucosa, so they have not been recommended for a long time. Research shows that mother's milk is very, very good because it contains, especially the colostrum, it contains some help to fight the immunity for that baby. It has antibacterial properties is generally what I'm trying to say. There are different solutions that you can get from the pharmacy. I'm not mentioning any of them because we weren't talking about labels today. And so you would take whatever swab that you're using with whatever fluid you're using, and you would go all around the baby's mouth, make sure that you get under the tongue, that you go along the gum line, both upper and lower. And if the baby is intubated, I would also do the portion of the tube that is inside the baby's mouth. We talked about the biofilm being very important for keeping the microorganism in that baby's system, and then when he swallows, he can aspirate that organism also. So I would make sure that you don't want especially if the baby's NPO, you don't want the swab dripping wet so that the secretions are pooling in the baby's mouth, but you do want it moist enough that you can see that there's moisture on the side of the baby's cheeks, on the gum line, under the tongue, etc., so that you know that that fluid is making a good splash, if you will, inside that baby's mouth so it can be effective.
So there's a question about, using mother's own milk versus donor milk. Is there any evidence about the use of donor milk for providing oral care in babies?
That's a really good question. I don't know if there is any evidence about that or not, but my thoughts on that would be, how old is the donor milk? So, for example, if we want to use the colostrum for that baby's mother's milk, we know that that is very effective. If let's say the mother who's donating this milk is now a month out from her pregnancy, so we'll say the express breast milk is about a month, it may or may not contain the same types of properties that the baby's own mother's colostrum will contain. And we do know that mother's milk individualizes itself, for lack of a better word, to that baby.
She was talking about the donor milk and whether it had the same amount of properties in it that you would with a mother that had just delivered in terms of the colostrum, and that would provide, we know how much benefit that colostrum has in terms of providing antibacterial properties to the neonate. So it is a question whether you would have that same amount of benefit from donor milk, particularly if there's no way of tracking when that donor milk was pumped in relation to when it was actually being used in that neonate. So I would look at that. I haven't seen any evidence that's really addressed that, but that's a great question. There were a couple of questions that had to do with the changing of respiratory circuits and inline suction catheters, and whether those were, how much humidity was in it. I think each of the institutions and NICUs may have different policies in terms of how often they're changed. Some may be as frequently as every 7 or 14 days, but it just depends. I think that if you notice you have a tubing that's heavily soiled, or has a lot of moisture in it, I think you have to realize that that sets up a great medium for bacterial growth, and that you may want to look at maybe changing that more frequently. And then there was a question about inline suctioning. And I think that, these tubings or ventilator tubings are sterile when you put them on. So it makes sense, just like when we think about breaking into an IV line or a central line, every time you break into that closed system, it increases the opportunity that you may introduce bacteria into that closed system. And so a lot of NICUs have really gone more toward using the inline suctions catheters for unintubated babies. So I think it's about really monitoring a variety of factors to keep the babies safe. Okay. And I think, while we're on that roll, a question about, changing of endotracheal tubes on a regular basis. I haven't seen any evidence or literature that really talks about that. But again, I think it would go along with the same kind of standards you would use in terms of changing your ventilator circuits, is changing your endotracheal tubes, depending on if it's a really difficult intubation, maybe not so much, but if your endotracheal tube is heavily soiled, then you can look at that.
Sounds like you're doing a great job, Marlene. Keep it up.
Well, I'm glad you're back. We have a question about, are there any guidelines on how soon you should start antibiotics on a mom who is GBS positive, depending on their term or preterm? What are the standards in terms of that first dose of antibiotic?
You want to start the antibiotics as soon as possible, irregardless if it's whether the pregnancy is preterm or term. The CDC has established excellent guidelines back in 1993, I believe, that shows care of the woman as well as care of the infants that may be contaminated or at risk for infection. Those standardized guidelines have actually cut the incidence of neonatal pneumonia by over 70%, even though GBS pneumonia remains our most offending organism. So the guideline is, as soon as the mom is known to be GBS positive, then she is started immediately on antibiotics. And we would really like to have 48 hours of antibiotics if possible, but even if the mom is going to deliver precipitously or in the next couple of hours, you still want to get those antibiotics on board.
Okay, we have a couple of questions that deal with the incidence of pneumonia as a neonate and some risk factors later into adult. Julie asked, is there any correlation between a primary CMV infection and later onset of asthma?
Okay. There are studies that have linked congenital infections, not just CMV, but in late onset infections, especially if the baby has chronic lung disease with asthma that developed as early childhood and persists throughout adulthood and can get worse. The number of infections or reinfections does make a difference and does increase the risk, as well as how long the baby has been intubated, how much oxygen the baby was on, and for how long, and what the duration of mechanical ventilation was. So yes, there is a correlation between chronic late onset pneumonia and asthma in adulthood.
Okay, we have a question from Sylvia about, do we need to worry about retrolinteral fibroplasia when ventilating newborns with pneumonia? Eye problems in preterms like retrolinteral fibroplasia.
I think you would just worry about that just like you worry about any other ill neonate.
I think I picked up enough of the gist of what you were saying, is that I think we need to worry about any baby, you know, in terms of oxygen exposure and that toxicity it may have on the developing eye in a preterm infant. But that's a great question. There was a question, I don't know what kind of systems you're familiar with, or Beth asked a question about, does the Ballard suction system assist to decrease the incidence of pneumonia? I'm not familiar with that system. I don't know if there's certain advantages of that system over other systems. Do you know anything about that?
Yes, I've worked with the Ballard system for many, 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 many years. We trialed them back in the 80s, actually. They do cut down on the incidence of infection, including pneumonia, simply because they're a closed circuit. And any closed circuit, the data is pretty much the same, just because you're not always opening the, taking the endotracheal tube off the ventilator circuit and then putting down a suction tube that may have been accidentally contaminated and the person doesn't know about it. So yes, Ballards are associated with decreased infection.
Okay. Great question. Tricia asked, if a mom's tested for HSV and tests positive, is there any guidelines you can do to protect the newborn?
Absolutely. It depends on whether this is mom's first infection or her second infection. If this is the mom's primary infection and it's done done during the pregnancy, she may not even know that she was infected with herpes. And so we may have a baby that's delivered with congenital herpes that we can't really treat. There's brain calcifications and pneumonia and systemic infection. If the mom is diagnosed at time of delivery, and again, these are women that don't show those genital warts or anything, if she has this infection and she delivers that baby, I think I said there was a 50% risk that the baby will develop the herpes. And so you have to be very vigilant for the first week of that baby's life, especially if he was born vaginally, to look at that presenting part for the presence of any vesicles or pustules that may show that the baby has herpes. If the mom was, and so if we know that mom was infected with herpes during this pregnancy, this is her primary infection, she will be delivered by cesarean section, and that will decrease the transmission rate to less than 5%. If mom has had herpes before, even if she has an active herpes now, they'll probably still deliver her by C-section, but even if they do a vaginal delivery, the risk is less than 5%. Colonization is high, infection is low.
Okay, I think we're just about out of time. I want to thank all of you for your wonderful questions. Thanks again to Dr. Verklin for a very informative webinar, and for all of you that attended and submitted questions. At this time, I would like to turn over the microphone back over to Emily.
I'd like to thank you very much for your time, both Therese for this wonderful presentation, and as well to you, Marlene, for being our moderator today. It's been such a pleasure working with you both. And I'd like to thank our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.